Good morning, everyone. My name is Ann Greiner. I'm President and CEO of the Primary Care Collaborative, and I am delighted to welcome all of you to our last Lunch and Learn of 2022. And we've been having a wonderful time having discussions about seminal primary care research, both clinical research and health services research. As a result of a survey, we combined both of them in our Lunch and Learn. It seems that those that join our conversations like to think about both topics, or both kinds of research, I should say. I did want to let you know that our evidence report for 2022 will be coming out next month. We'll have a notice going out shortly on November 16th, and I'll give you a little heads up. The title of the evidence report this year is Relationships Matter. How usual is usual source of care in parens primary care. And we all know how critical an ongoing relationship is to population health outcomes and equity and cost. So we'll be looking at trends across states, across demographic groups, across different kinds of insurance, and understanding what might be driving those trends. So I hope that you will join us for the release of our report. We'll also be discussing it at our conference, which is on December 14th and 15th. And at our conference, we'll be considering all the ways the primary care community is advancing the recommendations in the National Academy of Science, Engineering, and Medicine report. So come celebrate with us. The community is moving together, is coming together to make changes that will enable the primary care platform to be stronger and deliver all that we know it can for patients. Now over to you, Noah, to provide some other announcements and to get this party started.
Great. So yeah, thank you, everyone. I just have a few additional announcements. So we have our October webinar this week. So that's on October 27th from 1 to 2. And the topic is on paying for behavioral health integration. We have a great panel of speakers, and then that discussion will be moderated by Ann Greiner. And I can put the registration link in the chat if you'd like to attend that meeting. I also wanted to share that we have our registration for PCC's annual conference. So this will be in person just on December 14th and 15th. And we really hope that you can join the conference and help to advance the primary care NASM recommendations. And I'll also put the link in the chat for this conference, and we hope you can attend. A few other kind of housekeeping things. So as Ann had mentioned, this is our last Lunch and Learn for this year. And so we're doing some evaluations of the project. So keep your eyes out for a evaluation survey that's already been sent out, but keep your eyes out to complete an evaluation of kind of our dissemination efforts. As another reminder, if you can, stay muted while the speakers are presenting, and then if you have any questions that come up, please put those in the chat, and I will be monitoring the chat and sharing them with the co-chairs to have to bring to our speakers. And then finally, I'd like to thank our, two Lunch and Learn co-chairs for leading these discussions, Irene Donkler-Mullen and Jack Westfall. And yeah, I think with that, I'd like to pass it over to Dr. Irene to introduce our first speaker and article that we'll be discussing.
Great, wonderful. Thank you so much, Noah. I'm also really delighted to introduce Dr. Philip Day, who is going to speak on a really important topic. I think this is a child abuse, and especially in global settings, is prevalent. It's an uncomfortable fact that we are not screening. When I read about this, as many children as we're supposed to be, and so I think I'm really delighted that we've chosen to talk about this and learn from what Dr. Philip Day and his team did. So I'll introduce him and we'll get onto the talk, and hopefully we'll have some interesting discussion around this. So he is assistant professor and associate director of education in the Department of Family Medicine and Community Health at University of Massachusetts Chan Medical School. He is a philosopher and applied ethicist by training. Dr. Day also focuses on educational research, community-based participatory research, and the intersection of ethics and education in primary care practice. So he's currently the co-chair for the Ethics and Humanities Collaborative for STFM, so the School of Family Medicine, and has served as an ethics reviewer for the EPA since 2020. So thank you for coming here to share your study, and I will hand it over to you, Dr. Day.
Thank you, Dr. Irene. And thank you all for coming today to listen to me talk really briefly about the pediatric HITSS, and thank you very much for that introduction. Next slide, please. No, so I just want to first say that I don't have any conflict of interest to disclose, and neither does my team. If you get next slide, please, who I really must give a shout out to Dr. Shakil, who's the PI of this study and has been working on these HIT studies for about 25 years now. We'll talk about that a little bit later. Jessica Chu, Dr. Sarah Woods, and Kate Bridges, all of my former colleagues at UT Southwestern in Dallas. And there you can see the full citation for the PedHITSS, as we call her, the pediatric HITSS, if you want to look it up or incorporate it into your clinical practice, as I'd encourage you to do so. Next slide, please. So a little bit of background, and it's not good news. It's good that the numbers and rates of CPS reports, child abuse victims, and victims who die from death, excuse me. Child abuse victims who die from their abuse and neglect have all decreased in the last 5 years. This number from 2020 from HHS is the most recently reported. And if you look at the third section there, you can see that most of the victims are victims of neglect. About 16.5 are physically abused, and a little under 10% are sexually abused. Now, the PedHITSS, the pediatric HITSS, does not screen for neglect, and we can talk a little bit about that in the discussion, but it does screen for these other types of child abuse and maltreatment. Next slide, please. And so if we look at violence screening in primary care, the research on it is sporadic. The methods are usually heterogeneous, and it's just sort of in different kinds of settings. And so if we look at this first study, when looking at PCPs, this is an old study. Again, looking at the literature, it's not like there's a study every year that comes out or every few years. So this study of PCPs from 1999 showed that routine screening was done anywhere from 10 to about 11% for IPV in pediatric primary care settings. The next one shows that when abuse is or maltreatment is suspected, more than half of physicians and about 60% of PAs don't report all cases of suspected abuse, and more than a quarter suspect maltreatment or abuse and do not report it. And so if we also then look to the third one, in terms of routine or universal screening, it only happens about 12% of the time, with almost a third of PCP saying they don't screen for domestic violence at all. And one of the reasons could be, and this final block down there is from a review of the literature from 2017, could be that there's no comprehensive tool that can assess all forms of child abuse and neglect. Now, again, the pediatric HITS does not screen for neglect, but it does screen for all other types of child abuse and maltreatment. Next slide, please. And so if we look at what those studies tell us about what the barriers to screening are, we think about bias and discomfort from the provider, a lack of time, which is, sort of common in every clinical setting, inadequate training, and a lack of effective screening tools. And so we sort of think that the PedHITSS, the pediatric HITS, can definitely overcome the final three. No, if you could hit advance, there you go. The final three, for sure, that was what the pediatric HITS was designed for. And we think that the validity and the cut point that you can, that the PedHITS provides, perhaps can overcome some of the bias and discomfort from having a more objective tool for screening. Next slide, please. And so this is the pediatric HITS itself. And so the research question or our study was to validate this 5-item screening assessment to a tool to screen for childhood physical and sexual abuse in clinical settings. And you can see those 5 domains right there. And we're going to talk about what these match onto, but they specifically, and know if you could hit the advance a couple of times, it screens for physical, psychological, verbal, and sexual abuse. And you can see the question is, during the last year, how often would you estimate that an immediate family member did each of the following to a child? Given the nature of this study, we had parents and guardians fill out both the pediatric HITS and the conflict tactic scales, the parent-child version. Next slide, please. And so here's the study itself. We recruited a little over 400 participants from primary care clinics for what we call our not at risk or the non-abuse subsample. And then to enroll for the at risk or the abuse subsample, we recruited children and their parents from a at-risk clinic in a children's hospital where the study was conducted, and a women and children's shelter. We had participants fill out the CTSPC and the PedHITS. CTSPC is considered the gold standard in research settings for screening for child abuse, maltreatment. And then in terms of assessing this, they were followed, the assessments were completed after a primary care visit for the non-abuse subsample or following a counseling appointment for the abuse subsample. And in terms of status, the abuse status of the participants was confirmed either via an existing report to CPS or through whatever that particular site's intake procedures were that confirmed the abuse. Next slide, please. And so here are our results. In terms of our at-risk subsample, most were female, most spoke Spanish. About 41%, as you see right there, were Black or African American. A little over a third were Hispanic. Our not at risk or non-abuse subsample were a little more than half were male. Again, most spoke English, most were Hispanic, and about a fifth were white. All 5 of the PedHITS, 5 of the 5 items on the pediatric HITS, strongly correlated with the CTSPC's 24 items. And you can look at the paper itself to see all the methodological, all the methodology, the different validity tests that were done to essentially map the PedHITS onto the CTSPC. So we found that the pediatric HITS was more accurate at identifying group membership. That is to say, it was better at screening for those children who were abused and those who were not. And the pediatric HITS gives an optimal cut point of 1, which is to say any positive response should prompt follow-up. And again, this is a screening tool. So any response to this should result in some kind of follow-up from the provider, and that doesn't necessarily mean a report to CPS. Next slide, please. So in conclusion, it's a 5-item validated screening tool that we think should be used in clinical settings. PedHITS performs well as the gold standard CTSPC, but without the complex scoring. CTSPC has we find to be a very complex scoring system that is difficult for clinicians to perform and react to in any kind of reasonable amount of time. And it takes longer to fill out. The PedHITSS, when we were developing this study, takes about a minute to 2 minutes to fill out, so it can be done really quickly. There are, of course, limitations, the social desirability bias of our participants, the fact that parents and guardians completed the assessment. And again, for the third time, it does not assess neglect, which is the largest form of child abuse and maltreatment. And due to the constraints, which were very reasonable and ethical, put on us by the IRB, but also in line with wanting to, protect our participants, their privacy and confidentiality, we didn't have any mechanism for tracking our participants. We only got verbal consent for this study because the IRB and the sites did not want any record of participation in this study, which we think makes sense. So in conclusion, the findings of our study suggest that the pediatric HITS is a valid and reliable tool to screen for physical, psychological, verbal, and sexual abuse in children ages 12 years and under in clinical settings. Next slide, Noah, and the final slide. There are other HIT studies. As I said, Dr. Shakil has been working on these since the late 90s. And the HIT has been validated for male and female adults. In 2010, it was validated to add the sexual abuse question. It's been validated for verbal administration, which sometimes is more acceptable and faster in clinical settings. And we have a forthcoming teen HIT, or the adolescent version of the pediatric HIT, that should be published in Family Medicine, I think in November or December. And that one is filled out by the adolescents themselves, not the parents or the guardians. And that's it. Thank you very much.
Wow, thank you. That was great. Thank you. Wonderful. I have just a couple clarifying questions. One is you mentioned that the questions were tailored to family members. And I guess, does it also apply to friends or family members? Because sometimes there can be settings where it's actually that includes that. So I'm assuming.
So for the pediatric HITS, the question itself does say family member.
Right.
This pediatric HIT, the PedHITS has been used, and I actually just received an email last week for it to be used in Nepal. It has been used in many other countries and expanded beyond just family members to other people that might be in the household members, or other parents or guardians. But in the original form, it is immediate family member. Okay, so those questions can be tailored so that it includes that. And the other clarifying question is, so this is used for, it was applied to kids 12 and under. And a lot of the times, I mean, there's been some studies where if you ask college students that they've experienced, some form of abuse, can this also be applied to older, the 12 and over to 19, I mean, tailored to that? Yeah, I mean, what we think is the sort of general utility of the HITS is that it's been validated now from people 0 to 65. Okay. I mean, the next study, which was halted due to COVID, was a geriatric version of the HITS or for elder abuse. So because what we think that what the ultimate usage of the HITS should be is that, since it's been validated for any age, is that you could use it for any patient in any setting, right? In family medicine, the discipline that I work in, you see children from the womb to the tomb, right, as they say, right? And so, we think that once validated in all settings, then it could just be another standard screener that can be used regardless of what patient comes into the clinic. And you don't need to change any of the scoring or any of it. The only thing would be, does the parent or guardian for a child fill it out, or does the teenager, and that's the teen HITS, which is coming, was filled out by the teenagers themselves. Adult hits filled out by the adults. And yeah, so anybody could do it.
Great. So questions are coming in the chat, and Marjorie had a comment in which I think it's
yes, I wonder how often physicians are threatened over issues of reporting child abuse. And I wrote my own little story in there. Basically, I didn't say everything, but a child had obvious child abuse, was brought into our office, and we immediately called thankfully we're right next to the hospital and we have a lot of support for this. And the child had to be admitted and did not have great outcomes all the way up, all 4 fingers. And was witnessed by the mother, but supposedly it was the child who decided to crawl on the stove and put their hands in down to their palms. And of course, we didn't believe that. At any rate, I was threatened. And I wonder how often clinicians have been threatened over reports of child abuse, and if that's one of the inhibitors, and about what happens with the end result of filling this out. So it's used a lot. It's great. What do we know about the final outcomes of that down the road?
Yeah, so I can't speak to the first one. I'm not a clinician. I'm sure that we have plenty of men here who could probably chime in with some other unfortunate stories and that way. So the intended use, again, the pediatric hits or any of the hits, we have used them also for research purposes, and it was included at my former site as part of a universal screener with the PhD2 and the GAD7 and these types of things. So, but again, based on our studies, we don't track participants. So we're not really sure in terms of follow-up what has happened with these children or with the people who have participated otherwise in our study. I mean, I will say that I give clerk-shaped lectures on screening for violence in primary care fairly routinely. And again, similarly to the studies we looked at before, it's sporadic, it's not done that often. And there are even fewer studies that ask physicians like, why don't you screen? From what I've seen, and I remember I don't like to quote numbers without having them in front of me, but it was over a decade ago was the last study that I saw. And the most common reason was lack of time, right? And then provider discomfort, right? Not being embarrassed or not feeling comfortable asking these questions. And so the intended use, or at least the way we think that the PedHITSS could be used, is again, alongside PhD2 or a GAD7, some other universal screener. Doesn't have to be done by the physician. In fact, most studies show that the highest rates of universal screening for intimate partner violence or domestic violence are usually conducted by non-physician medical staff, could be medical assistants or other types of providers. But in terms of the first one, I'm not really sure in terms of how it, how many physicians are threatened or otherwise find this to be unacceptable. There is, again, sporadic and infrequent literature that shows that most patients are okay being asked these types of questions, and in fact are glad to be asked these types of questions if they have good rapport with their physicians. And again, as someone who works in family medicine, that's sort of essential to the discipline.
Yep, thanks. And Jack had a question. Have you looked at a comparison between this tool or the PedHITSS HIT score and primary care clinician making a report to social services? Does this PedHITSS?
No, we have only, this study was only conducted in a research setting. We want people to implement this in their practice to see what it looks like empirically. Again, we've used it in other research studies to track, alongside ACEs to see what historical abuse and then what present abuse might be there for folks. But we and I don't know if Dr. Shakil he didn't say if he'd be able to make this call if he's used it or not. But I haven't seen it in real world usage settings, unfortunately. But we hope that this kind of talk will get it out there. And I'd love to hear from folks if you do implement it.
Yeah. There's a question about truthfulness or getting the right. So what % of screens would be assumed truthful responses from the parent or the guardian? And you had
I'm not sure that what it means in terms of would be assumed to be truthful. Again, we do think that social desirability could impact this this study, though. Again, the children that are at risk or those who had confirmed abuse were confirmed by not by us. They were done either through CPS or through these violent shelters or the at-risk shelter in the children's hospital. So, in that setting, I would say that 100% of them are truthful. In terms of the other side, I will say, and I think I'm low on time here, but I will say when we conducted the adolescent hits, we did find that in our primary care, not at risk, non-abuse subsample, we did have 3 positive responses. So even, so we do find that there is in those normal settings, we did find a few and we excluded them from the analysis because that's, for methodological concerns, we couldn't include them. So I'm not sure how much you would assume would be truthful, but again, we do hope that sort of by moving this outside of me asking you, but getting you to fill out a questionnaire, it does allow folks to be more truthful and to answer these questions honestly.
Well,
And again,
truthful. Oh, I'm sorry. I thought you had finished.
Yeah.
Parents, right? Like,
Mhm.
I think Marjorie was saying, they said the child had not had hurt themselves, but maybe it's actually the parents.
Yeah.
Oh.
Yeah. And again, like the pediatric hit is to prompt some kind of response from the provider with some kind of evidence that says it was verbal, physical, or psychological. And we think that there are many pathways or workflows that could flow from that, including, working with a behavioral health provider, family counselor, and only unless it is the sexual abuse question, and that itself is, binary in that way. We think there's only one response to that.
Yeah. And a quick question about neglect. Would that will be included in the tool, or is there another tool that can be?
We don't have any that for neglect. Neglect has like a different set of properties that you would need to screen for. I don't want this to sound like I'm just sort of dodging or punting the question. I'm not really sure when the HITSS was originally formulated back in the 90s, how or what the rationale was for not including neglect. But I would say that when we think about the next HITSS, the elder abuse HITSS, the geriatric abuse, that is also the most common form of elder abuse. And so how we had struggled to sort of how do we incorporate that into the tool itself. So it is a lingering issue, but we do hope that this 5-item screener, that takes a little over a minute to conduct, could be more, incorporated in the clinical practice.
Mm-hmm. Great. And I guess a final question, maybe one more, but how can this pediatric hit be incorporated into a clinic visit or a workflow? So
again, like the way that we would envision this would be, again, and not to sort of stand off the corners of the question, but like to whatever works for your clinical workflow. But we do find that non-physicians probably have more time at or as a pre-visit screener alongside the other sort of bank of forms that we all fill out when we go see the clinician. And if you look at what improves this sort of rapport with asking these questions, it's universal screening and incorporating it more into your workflow. So I recommend things like saying, we ask all patients these questions, or I want to talk to you about your relationships with your family members, right? After using the HITSS as a way to give some kind of information to a clinician.
Great. So thank you so much. Great presentation, great questions, and we'll keep comments in the chat, but I'll hand it over. I guess I'm handing it over to Dr. Westphal, right?
Yes, thank you, Dr. Irene. I really appreciate it. Thank you, Dr. Day, for that presentation. I'm excited to present and facilitate the next conversation. Patient-centered medical home implementation and improved chronic disease quality, a longitudinal observational study. Very excited to introduce Dr. Anne Marie Rosland is an associate professor of general internal medicine at the University of Pittsburgh and a core scientist at the VA Pittsburgh Center for Health Equity Research and Promotion. At Pitt, she directs the Caring for Complex Chronic Conditions Research Center. She leads stakeholder partnered healthcare research and initiatives aimed at improving healthcare and self-management support for diabetes and other chronic conditions, understand impacts of changes in primary care organization and policy, and innovations in care management and coordination. She received primary care clinical training at Penn Center for Primary Care and currently provides primary care to veterans at the VA healthcare system. I'm going to go ahead and introduce the article reactor as well so that she can begin immediately upon Dr. Rosland finishing up her presentation. Dr. Ann O'Malley is a primary care health service researcher, physician, and senior fellow at Mathematica Policy Research. She's the PI of the CPC Plus evaluation. Again, it's my honor to introduce and welcome Dr. Anne Marie Rosland, Patient-Centered Medical Home Implementation and Improved Chronic Disease Quality, a Longitudinal Observational Study.
Everyone, thanks so much for that introduction. I'm really excited to share this study with you that we published in 2018. This study was done as part of the VA healthcare system's national evaluation of its patient-centered medical home rollout as part of what is now called the Primary Care Analytics Team that I've been a member of for several years. And the director of that team and co-author of this study, Karen Nelson, is also attending the call today. So next slide, please. As a reminder, the Veterans Healthcare System is the largest integrated US healthcare system with, at the time we did the study, over 7 million primary care patients enrolled in the VA and over 16 million primary care encounters recorded around that time. And then the numbers on the right are more updated. 171 hospital-based primary care clinics and over 1,000 community-based primary care clinics right now nationally in the VA, and the map just shows you the different regions and reminds that we are also, VAs in Alaska and Puerto Rico and all over the place. The reason this is important to this study is that the VA rolled out the patient-centered medical home to all primary care clinics across the country at the same time over a 5-year period. So if we go to the next slide, the VA's PCMH model was called PACT, or Patient Aligned Care Teams, or it is called PAC, it's still there and going strong. The initial national implementation period went from 2010 to 2015, and it had elements that will be very familiar to people on this call. Patients were assigned to a multidisciplinary primary care team that they had continuity with over time. New patient access possibilities were put into place, on-demand scheduling, after hours, secure messaging, that kind of thing. And then nurses, social workers, others on the team were given tools and time to do care management and care coordination. This model was not just implemented across all the clinics in the system, but also across all the patients. So everybody got a team, everybody got this access. And for the most part, the model itself did not directly address care of chronic conditions like diabetes or hypertension. So if we click, okay, great. So the VA also funded an extensive evaluation at the same time, looking in general at clinical quality, health outcomes, patient quality of life, satisfaction, staff satisfaction, and whether we were able to reduce the burden of unnecessary utilization, excess costs. So this study looked at the topic on the top of clinical quality. Next slide, please. Great. So at the time we did this study in 2017, 2018, there were some limitations to the studies already out there on whether patient-centered medical home was linked with better clinical outcomes for chronic disease. So there were limited studies in general. Many of them looked at preventive care processes for clinical quality, like were you getting colon cancer screening, or maybe within a chronic condition, were you getting eye exams for diabetes, important things, but not yet getting much at, is the control of diabetes, hypertension improved? And a lot of the studies were limited to programs with, a small number of clinics, or targeted again to very specific patient populations like only the elderly or only people with diabetes, and just had access to a limited amount of data. So on the next slide, we took advantage of the fact that the VA had done this very extensively and had a lot of different data to ask whether VA primary care clinics with more extensive PCMH implementation had more improvement in chronic disease quality measures, again, in a program that included all enrolled primary care patients and really focused on what we called in our paper upstream patient care, center care processes, things that didn't directly address care of chronic conditions, but kind of set the context for it to be improved. So if you go to the next slide. So what did we find? First, I'll show you our results for process of care metrics, and then after this, clinical outcome metrics. The process of care metrics we evaluated are across the bottom, and the change in the percent of eligible primary care patients that met the metric from 2009, so that was right before the PCMH came into effect, up until 2013, that level of change over those years are in the gray bars. So you can see the line that corresponds with 0% change. A bar going up from 0 is an improvement over time, and something going down from 0 is a decrease in quality metrics being met over time. Since all the clinics were asked to implement PACT, we didn't have a control group per se. So what we did is we compared the clinics with the most PCMH implementation via a score that was developed internally called the PI2 score, PACT Implementation Index. So we compared the clinics that were the highest on that to those that were the lowest. And in the paper, we also report kind of what happened to the clinics in between. But here I show the biggest contrast. And the last thing I'll say about the analyses is that, the biggest threat to our analyses is that, there might be something else special about clinics that implemented PCMH successfully that also allowed them to improve chronic disease quality. So we adjusted for as many of those things as we could, including, what was the clinic's level of quality before PCMH, where were they located, what type of clinic, what size, and we even adjusted for the area unemployment rate around the clinic. So in the process measures, you'll see with the little stars that we found a few significant improvements in process in high PCMH clinics, including whether LDL were measured in CAD and whether A1Cs were measured in diabetes, and even one that went in the opposite direction that we expected, which was the ACE and ARB prescription in diabetes. One thing to note about these is that most clinics for these measures started at pretty high baseline levels already, high baseline performance. So there wasn't a lot of room for anyone to improve. But if you look at the next slide, on the other hand, great. When we looked at measures of chronic condition physiologic control, which match HEDIS and other very standard quality metrics, we found that most of them improved significantly more in high PCMH clinics, including whether LDL was under 100 in CAD or under 100 in diabetes, whether people with diabetes were achieving blood pressures less than 160 over 100, and then a couple that went in the direction we expected, but were not statistically significant. And then also 2 other measures of BP achievement in people with hypertension. And this was exciting. And one thing to remember about when you interpret this is that if you spread these changes out over 10 million patients, say in the VA, about 30% have diabetes. So a 1% change corresponds to about 300,000 people with diabetes newly meeting a quality metric. Okay, next slide. Last but not least, I was invited to address future directions, and this is a study we just published, also with the VA primary care analytic team. At the same time the VA implemented PCMH, they also implemented integrated or co-located mental health services and primary care, also across the country. So previously that was linked in the VA to more use of mental health services and better mental health quality of care. So we asked whether VA primary care clinics who implemented integrated mental health care to a greater extent also saw impacts on chronic condition quality. And so next slide. We adjusted for the amount of patient-centered medical home the clinic had. So even with removing those effects that we already saw, these charts show that as you move to the right basically, and you have higher proportion of patients in a clinic using integrated mental health services, that both A1C and blood pressure control quality was better. So last slide. So in conclusion, we found that health systems, or our conclusion that we came to after these studies is that health systems that invest resources in patient-centered medical home and, an integrated mental health care delivery across all patients might see some downstream improvements in their chronic disease quality measures, including control of diabetes and hypertension. Thanks.
Anne, I think you're up for a response.
Can you hear me?
Yes, now we can hear you.
Phew. My microphone did something spazzy during Anyway, thanks, Dr. Rosland. That was a really nice presentation and study. So I was asked to comment on the study and then place kind of those findings kind of in the context of what we're learning from CMMI primary care models, in particular, the comprehensive primary care models that we've been evaluating at Mathematica. And then I would like to kind of open up discussion, particularly on a couple of topics that I think are really important for us to think about going forward, as well as anything else folks want to discuss. So first on Dr. Rosland and colleagues' study, I mean, it's a nice effort to bring in the patient-reported experiences in primary care as part of their measure of implementation. We know how important that is. I think another strength of the study is its use of objective data to capture access and continuity from their corporate data warehouse. So instead of, it gets us away from relying just on practice self-report, which we know can sometimes be biased, or there can be some over-reporting there. And I think a third strength of the study is that, you're looking at a range of clinical quality indicators over time. So you've lots of conditions. You're not just picking on 2 or 3 things that might be easier to move the needle on. So I congratulate you on all that work. So how do we place your findings or these findings in the context of our findings to date on the Comprehensive Primary Care Plus initiative, which we call CPC Plus, and its precursor, Comprehensive Primary Care Classic? Just as a reminder, CPC Plus is the largest multi-payer medical home model in the US to date. And its goal is to support primary care through enhanced payments, supports to practices, and formal care delivery requirements, where they really ask practices to enhance access, continuity, coordination, comprehensiveness, care management, and population health for practices. It's a 5-year-long model with CMS and other commercial payers as well as Medicaid. So given the mission under CMMI of potential scalability of these models, should they show either improved quality at a neutral cost or reductions in cost and expenditures with similar quality, our evaluation of CPC Plus and those types of models is held to a really high bar. So first of all, we have to have a control group. So we have a match comparison group of practices that look just like CPC Plus practices in every other way. And we've got to demonstrate changes over time from baseline to follow up at the end of the model in both implementations. We have to see changes in how they implement the model differently, as well as in the outcome. So that's a super high bar for us. I'll also note that we don't have access to data on these clinical quality indicators for our comparison practices because we just don't get those clinical data. So we really have to rely on claims-based measures of quality indicators. So having said all that, it's a bit of an apples to oranges comparison to try to compare Dr. Rosland's work on quality indicators with what we're learning in CPC Plus, but I will try nonetheless, given all those constraints in design that I just explained to you. So over the first 4 years of the model, we're in the 5th year now, But in the first 4 years of the model, there were some small improvements in some of the clinical quality metrics when we compared the CPC plus practices to a matched group of comparison practices. For example, we found that there were increases in the percentages of Medicare beneficiaries who had received all recommended services for diabetes. In females, we saw increases in breast cancer screening in terms of evidence-based screening, and we saw some small increases in hospice use. Unfortunately, one of the other things we mentioned did not improve, and that's use of appropriate medications, particularly in the older population. But an additional thing we kind of added later on and we found improved pretty consistently across our model was reduction in the overuse of opioid prescriptions. So that's a real important thing that we've discovered, and Helena Zurovic on our team has done that work. So having said all of that, I guess I'd like to maybe throw out for discussion a couple of things that to me, I really thought a lot about when I was reading Emery's study, as well as kind of grappling with CPC and CPC Plus as part of a very huge team that we have here at Mathematica over the last 10 years. And the first of those is that, measuring and quantifying the degree to which practices implement these multifaceted primary care medical home models is really tricky. And it requires us to capture nuance. As part of our CPC Plus evaluation, we spend a lot of time and energy doing site visits to practices, interviewing practitioners on the ground and all their team members to really hear about how's the model rolling out, how are you implementing, if at all, these things, what are the barriers and facilitators to implementation, et cetera. And we learn a lot from those that give us pause in interpreting some of the survey findings. The second thing maybe we could discuss if we have time is, how should we measure primary care quality going forward? Yes, obviously we want practices to do well on these clinical quality indicators that Dr. Rosland and others are mentioning, but primary care is so much more than the management of any individual condition. It's the management of the whole person across all of their conditions. It's continuous, coordinated, comprehensive care. And primary care really needs to get credit for the hard work they do in delivering that type of care. And I think there are some limitations in our quality metrics, obviously, in the extent to which we can really capture that. So I'll be quiet now and open this up to discussion.
Thank you very much, Dr. O'Malley. And Dr. Rosland, I'll just turn it over to you to respond to those comments. And then there's a couple of questions that have come in via some other chats and some other methods. So if you want to respond to those first comments, that'd be great.
Sure. There was a lot of interesting information there, but I'll pick out a couple of things. I really I'm really glad that Dr. O'Malley from the CPC evaluation is able to be here, because I really think of that project and that team as kindred spirits. And, definitely with our findings and programs can give us complementary information on the PCMH model. I agree. I agree that the index that we used, and I'll shout out again to Dr. Kari Nelson, who may still be here, who developed that PACT implementation index using, as you pointed out, a lot of administrative data in addition to patient satisfaction data to really get a better handle on how much practices were objectively implementing PCMH was a key factor in us being able to do this study. I also agree that the chronic disease quality is not the end all be all of patient-centered medical home implementation or primary care for that matter. And as I showed in the beginning of my slides, there were multiple outcomes that I would say the program equally valued, including patient satisfaction and even staff burnout. So I really was happy to see that all those things were sort of looked at, one piece at a time. So on the other hand, I think that, the ideal scenario is that if we can show that people are happier with their care, they can access it, they're more satisfied, and they're, control of diabetes and hypertension goes down, that's kind of the holy grail. So hopefully this is one piece of useful information about that.
Thank you, Dr. Rosland. So there's been a couple of comments come in, and one relates to sort of patient engagement. And I saw that you do some engaged work as well. And I'm curious how patients were involved in the PCMH implementation in these practices. Were they simply involved and engaged through engagement in their care, or at what point were they, and how were they involved as practice informants or co-creators in the system? And then the second question of that is, how were patient satisfaction survey results incorporated?
That's a great question. And as far as the first part about the design of the rollout, the VA has a long track record of involving patient stakeholders in most things. I don't know the specific answer to how patients were involved in the design of the PCMH rollout, in 2008, 2009. Unfortunately, I can't answer that question. But I know that it was piloted at a few specific sites before it was, rolled out to the country. But as far as patient voice in the evaluation, we used VA data that basically was from the VA's version of the CAPS, patient experiences survey. And some of that data was used to create as some of the components of the PACT implementation score itself, whether patients rated access high, for example, in addition to other access metrics like wait till third appointment, stuff like that. So there's a combination of patient input and other data. And then in other studies, other than the one I showed you today, but other evaluation studies, the impacts on patient satisfaction, apart from those that were in the index itself, was evaluated just separately from this. Yeah.
Thank you very much. In just the last minute or two, I'm a big believer in the patient-centered medical home and advanced primary care, and I'm curious if you have any thoughts or early data or any hypotheticals on how the work that these 800 clinics did to become patient-centered medical homes prepared them for a pandemic. And is there any evidence around these 800, their response to a pandemic versus other clinics, whether that's data or anecdotal or stories you've heard? I'm just curious what 10 years of being a PCMH did to prepare a practice.
Wow. So that's a big question. I love that question. And I'm writing down as a new next research question, did practices with more PCMH see less changes in quality, for example? A couple of easy things I can tell you that the VA was just sort of primed and ready to go. One of them was, some of the access that had already been put into place was already video visits. A lot of video visit capability and actual video visits were already happening before the pandemic started. So, that was, it was ramped up a lot, but it already existed and was kind of a lot easier to scale up from, pretty early on. The other thing was sort of one of the care coordination tactics that the multidisciplinary teams used. People had weekly huddles where they reviewed panels of patients. So for different, kind of missing different things. And so that was very quickly deployed into what the VA called a preventive health inventory. Basically, they reached out, nurses would look and see if people were missing basic stuff like their mammograms because of the pandemic, and reaching out by phone to try to get them to arrange it, even if they couldn't see the provider in person, to get them to be able to get their key testing. So I feel like some of those systems that were already in place were easy to, using military language, like deploy and ramp up, in that setting. So.
Thank you so much. That's the time we have right now. This was fantastic. I really appreciate your presentation. Dr. O'Malley, your comments, and the rest of the questions and answers. There's a lot in the chat that we couldn't get to, and I look forward to, I'm hoping that people will continue to make connections. I think at least Dr. Day put his email in there, and if Dr. Rosland and Dr. O'Malley feel comfortable, they could put their email contacts into that chat. And I'm going to turn it over to Noah.
Great. Yeah. Thank you so much to our speakers for great presentations and really engaging discussion. Just a final reminder to complete this quick less than 2 minute evaluation of the Lunch and Learn, just so we know, how we did and, how to improve the discussions in the future. And yeah, that's the last one for this year. So I'd like to hand it over to Anne for any final words.
Thank you so much, Noah. And thanks for all of your incredible work and leadership on this PCORI project. And we look forward to continuing Lunch and Learns in 2023. And I particularly want to thank our dynamic duo of co-chairs, Dr. Irene Duncan-Mullins and Dr. Westfald. Irene and Jack, you've been terrific. You're such wonderful hosts of Lunch and Learns, and also our speakers. It was a delight. One question I have for Anne Marie is usual source of care and how that works in the VA, because patients had so many questions about COVID, about vaccines, and I do wonder if usual source of care is, one of those elements that helped VA practices perhaps do better and their patients to get better outcomes. Thank you again for joining us. Please look out for our evidence report release on November 16th. Come to our conference, and it would been a delight to spend this hour with you all.
Thank you all.